Morning, good morning. How is everybody out there this morning? Today is, let's see, what is today? This is Lizette. I'm going to start the uh, program here in a second. I'm just trying to get my brain organized. This is Lizette. I am from the Baffled Brain, Demystifying Dementia. This is my weekly hour-long Facebook Live that will teach you everything you want to know about how to manage dementia. Today is February the 20th, and this is episode 13. And I'm your host, Lizette Klute from Think Different Dementia, where we believe caregivers deserve reliable answers to questions to provide clarity and improved quality of life. Because having actionable strategies and information gives caregivers and people with dementia improved quality of life and better relationships. Good morning, everybody. How are you? Like I said, this is Saturday, February the 20th, 2021, and I am really excited to be here today. We're going up to Greenville, South Carolina to go visit my dad. It is his birthday on Monday, so lots of excitement here. I see a couple people on. If you have questions, please throw your questions in the comment section, and you know I will get to them. Hi, Eunice. Good morning. So this hour is for you. This hour is for you to ask questions about dementia or anything that you are struggling with. So Eunice, if you have a question, please throw it out there. So I thought I would start. I've started keeping track of questions I'm answering on this group, in this big large group that we're in. I started to keep a little list of questions, and I decided I have a goal for myself, and I hope you guys can help me meet my goal this year. My goal is going to be to answer 1,000. That's 1,000 dementia-related questions in 2021. And I am behind, so it's all good. So I'm going to answer a question. I'm just going to start with some questions that I have here on my cheat sheet, and then if you have questions, please throw them out there, and I would be happy to answer them. So Sherry said she's fairly new to this caregiver thing. She says her husband has it, and she feels stuck in a situation that she won't be able to handle. She has many of her own issues, including post-traumatic stress, and she's 73 and not exactly strong. And her biggest fear is changing briefs or diapers. She says she's very germophobic or afraid of germs. And along with that, her husband is much larger than her and 10 inches taller. She says she can only hire help for a few hours a day and that a nursing home is not a reachable goal, and what advice I would have for her. So I'm going to start with this. So we're going to break it down a little bit at a time. She's sounds like new to this caregiver role and she feels stuck. Well, I am so very, very sorry, Sherry. I know it must be extremely difficult to feel like you're stuck in a situation that you have no control over and not able to handle. My job is to try to help give you the tools that you need in order to actually handle this. So I know you're in your 70s and not very strong, and that your biggest fear is changing diapers. So let's talk about changing briefs and changing diapers. That's like really late stages of the dementia journey. So I'm not going to say we're not going to talk about changing diapers, but if you're not at that stage yet, worrying about it for what's going to come down the line is not necessarily where I would start. I would start with you regarding, let's just talk about behaviors in general, right? Because when somebody is working with someone else who is a much larger person than them, when people start with their dementia journey, they typically have the cognitive impairment first, they have the trouble with their thinking processes first, and then the physical stuff comes later on, right? So when we have a caregiver who is significantly larger than the care provider, we always want to be aware of that. Having said that, there are a lot of strategies that we can use later on when we get to that point. At the beginning points, though, we want to make sure that the person who is providing the care is being able to actually cue the person or give them verbal cues or physical cues or tactile cues, you know, visual cues is the other one. So we have verbal cues, visual cues, and tactile cues, those three. So we want to first start to use cueing, how to get somebody to do something if they physically still have the strength. So a lot of times the person with dementia will still have enough strength to do these kinds of activities. They just do not have the cognitive ability to be able to do it. So if we start to teach people early on how to cue their loved one with dementia, it can really help protect the care provider, who is not necessarily as big as the person that they're caring for. So the first advice I would have for you is reach out to me again in the other Facebook group, Think Different Dementia, and we will start a dialogue about how to cue people, how to be able to help a person just verbally before you have to help them physically. And so I know I haven't addressed the changing diapers phase. It doesn't sound like you're there yet, Sherry. So let's start with just how to keep you safe and how to keep him safe. And then as we're walking through this journey together, we can start to talk about some of the other stuff that you're having trouble with. So good morning, Ralph. Good morning, John. I am so glad to see you guys here. If any of you guys out there have any questions for me, particular questions for me, so I am gonna wait a second for anybody to hop on and give a question. So I had a great question from Renee earlier this week, also in my private Facebook group called Think Different Dementia. Renee had a question. She said, so I'm going to keep doing these questions until somebody on live asks me a question, and then we'll go to that question. So please hop on and ask questions live. I'm so glad you guys are here. Thanks, Julia. So Renee's question was, she cares for her dad. Her mother cares for her dad 24 hours a day, 7 days a week, even though he has a CNA or PCT, right? He has somebody who comes in 4 hours a day for four days a week. That being said, she won't let go of anything except bathing. She'll let the care provider do bathing for her dad. Other than that, the caregiver is sitting there for 3.5 hours a day getting paid for not doing anything, and obviously that's frustrating to Miss Renee. And her question was, at times her dad seems to get really stubborn and resisting doing things he's asked to do. So her mom, and this was her observation, her mom gets really frustrated and raises her voice and counts to 3 like he's a child, and her word says gets pretty sideways with him, right? So she's asked her mom not to be so confrontational and not give her dad ultimatums to do things to see if he will cooperate more. And she feels at a loss because she herself has some serious health issues, and so she's not in a position to actually help her mom take care of her dad, right? And she says that her dad has always been the care provider to her mom, and now the tables are turned and she is needing to be the care provider and is having a lot of difficulty adjusting to the differences. Renee herself cannot drive, so her mom cannot drive, so she depends on her daughter and her husband to do that. What advice has worked or is working with your loved ones at this stage? When she says when her mom can't take it anymore, she tells her dad she's going to put him in a nursing home, which only makes Daddy say that they don't love him, or he doesn't love them, he wants them out of the house, or he cries and he says he cannot go into a nursing home because he won't be cared for, and it's her job to take care of him. So I kind of answered that question in a different live, yet again in my private Facebook group, but I'm going to answer it again here because I think this is a really good way to break things down for people. So there are a lot of things going on when people have dementia, right? And the first thing that I want everybody to remember is that there's almost an inverse relationship between the person with dementia is slowly going backwards, and the person who's the care provider is slowly needing to provide more care. So there's an inverse relationship to it. But when we understand why some of the stuff is happening, and I'm just going to talk quickly regarding his. I'm going to start at the back end. I'm going to start with her dad's responses to her mom's intervention, right? So something her mom is saying is triggering her dad's behavior, his being stubborn, his not wanting to do things for them. So part of dementia is the people lose the what we call the executive functioning, right? So the executive functioning part of it is the higher level parts of our brain. So when we develop from normal development. Everybody has normal development, right? From a child growing up. When we hit about 12 to 14 years old, we start to develop what's called executive functioning. Things like time management, things like emotional regulation, things like your ability to anticipate secondary consequences of things, right? All of those higher level things. So as a person is going through dementia, those higher level things, think like an onion, right? The outer levels of the onion are starting to go away. And so the first thing that I see here is what he is saying to mom is his emotional regulation. So he's lost the ability to emotionally regulate what's going on. I want people out of my house. He doesn't anticipate, he's not seeing the secondary consequences of what's going on. So that's kind of setting the stage. Then we're going to go back to mom, right? So what are behaviors? When people are starting to have what we call challenging behaviors, or another word for it is negative behaviors, or just behaviors, right? What are behaviors? People demonstrate behaviors because they are losing the ability to communicate with you. Think about a child, right? A 2-year-old. When a 2-year-old's throwing a temper tantrum, why are they throwing a temper tantrum? A 2-year-old is throwing a temper tantrum because they're trying to communicate something to you. I didn't get my way. I'm tired. I'm hungry. I'm cold. I'm frustrated. I didn't get my way. I don't like what you're making me do. When adults with dementia start to have negative behaviors, or challenging behaviors, which in her question was getting really stubborn and resisting of care, right? That's the behavior. He's stubborn. He's demonstrating stubbornness and resisting of care. So the resisting of care and stubbornness are kind of the same thing when I look at this problem. So we look at the problem, right? We have a problem. Well, what we want to do is we want to look and see what happened before. If you think about a person with dementia having a challenging behavior, and think about it, they're trying to communicate something to you. And you look at what happened before, you want to be very specific. Who was there? What did they do? What were what happened? Was it a certain time of day? Were there certain care people there? Is the care provider there? Is it who is there? Set the stage. Make it like a movie, right? Run it back through your head and say, oh, this is all the stuff that happened. Was it always in the same place in the house? Was it always at the same time of day? Was it always, who was there? And then try to look and see what triggered that behavior. That behavior, that communication that person's trying to do is very specific to something going on. It can be, so there are 3 things that we're looking at in that situation: the caregiver, the environment, and the person with dementia. Are they constipated? Are they tired? Are they hurting? Are they cold? Are they hot? The environment. Too much going on. The TV running, the radio running, 15 people talking to them, everybody throwing answers at them over and over, saying to them, come on, let's go, let's do this, all of those kinds of things. And then just the caregiver themselves. Are they stressed? Are they picking up that they're stressed? all of that. So we want to look at those three things in the trigger part of it. So the antecedent, the before, the behavior, the during, and then the after. What's the consequences? The temper tantrum, or we have to go to the room, or somebody had to leave, or all of those kinds of things. We don't only want to look at the behavior when the behavior is happening, because then we only see the trigger of what triggered it right at that time. Well, what if we turn it around, right? The times when the behavior is not, when he is not stubborn, when he's not resisting care, what's different? What's different in the before? Because we want to try to set the stage then for managing the behavior using these kinds of environmental, caregiver, and person with dementia effect. We want to make sure that that is always optimal. So I told, Renee said after I did this live, she said that she would try to see if she could see what some of the triggers are. So if you have people who are being who are demonstrating these challenging behaviors, try to start a dementia diary, right? Try to start a behavior diary so that you can see. So far, nobody online has thrown me any questions, so please go ahead and throw me questions. Miss Eunice, you had made a comment earlier that you're struggling this week. Tell me how I can help you. What kind of struggles are you having? For people watching, Eunice's mom passed away very recently, and she's in South Africa, and we kind of have a dialogue and a friendship going on over the internet, which is kind of super cool. I pray for Eunice frequently. I know it is very hard. She was her mom's primary caregiver. A lot of people who lose loved ones with dementia, it is very expected, Eunice, to go through a period of grief. It is very expected to have denial about the fact that mom's passed away, to be angry, to bargain with God and say, why did you do this? All of these stages are very, very normal. There are 5 stages of grief. I did not pull those up, so I'm sorry. It's been a while since I've done that. So just remember what you are feeling and what you are experiencing is entirely normal. It doesn't make it easier. I get that. But I also know, and this is something that freaks people out after they have had a loved one pass away, especially if they have had cognitive decline. Their loved one had cognitive decline before they passed. It is very normal for a person who has had death in the family, especially if they've been the care provider, for them to have changes in their own thinking processes. That is normal. I don't want you to freak out if you feel like you're not thinking clearly. It's highly possible and not abnormal. It can take upwards of several months before your brain will go back to being normal and not feeling like it's mush. Depression can cause people's cognitive capacities to decrease. And a lot of people out here who are care providers to other people who have dementia or so on may have their own, and this is a hard thing to think about, because most care providers, most people who are helping other people with dementia are very aware themselves of their own cognitive impairment or potential cognitive impairment, because we are petrified. My parents have cognitive changes, and we are petrified of developing dementia ourselves. So the slightest little bit of changes in our own thinking make us think that, oh my gosh, I have dementia too. 50% of caregivers have depression. That's a well-known statistic. 50% of caregivers have depression. And people with depression have sometimes demonstrate cognitive impairment that is not related to dementia. So I just wanted to kind of encourage you to not worry about that, because the more you stress over it and the more you worry over it, the worse it gets. So I hope that was helpful. So John, question back to bad behaviors. If there are triggers for bad behaviors, are there triggers for good behaviors? Yes. But I wouldn't. So, are there triggers for good behavior, and can they be used as motivators? Now, that's a great question. Motivators to gain cooperation. So, let's think about motivation. Um, to an extent, you might be able to use. So let's think about developmental processes. John William, I've never actually had this question before, so give me a second as I process through this. Challenging behaviors. If they're triggers for challenging behaviors, are there triggers for good behaviors, and can they be used as motivators to gain cooperation? So we're going to start with developmental because that's the way dementia regresses, is back sorted through the developmental phases. So as a child develops, early on there are certain motivators that you can use to elicit good behavior, but that child is still able to, they're kind of improving. So the motivators are going to be very concrete, right? If you don't do this, this will be the consequence. Or if you do this, then that will be the reward, right? The difference with this, in my mind, is that child does not have memory impairment. So as long as the person with dementia doesn't have memory impairment, we potentially, people with dementia have sometimes short-term memory impairment, but if they care about something well enough, up to a certain point, they can still remember. So as long as they're maybe in the earlier phases, we can use maybe some motivators to help keep to be able to challenge behavior. But at some point or another, and that's a fairly high level thing, so I would say maybe with mild cognitive impairment and maybe with the first beginning little bit of phases of mild dementia, we might be able to do a little bit of that. But when people are not able to have the ability to anticipate secondary consequences of things, a motivator is not going to help. So it's going to be incumbent, John William, on the people who are around them to see what the triggers are. So the triggers for the good behavior are more likely going to be environmental. They're more likely going to be the care provider and the person with dementia. You might be able to use some limited motivators, but it's really probably not going to be that effective if the person has, lost the ability to be motivated by external motivators. So it's worth a try. It may trigger a behavior, and you may have to be very specific with what your motivators are going to be. And like I said, higher level people with dementia who aren't as far into the dementia phases yet might be able to still use a motivator, but my gut tells me likely not. Usually, there's the initial phases, as long as, and this is always difficult for care providers to understand. There is a point, just because somebody starts down with dementia and they're having short-term memory issues, at the beginning they may actually still be able to learn new information. But the only way they can learn new information is if the person themselves, highly values that information. It's not if I, as the care provider, highly value that information. It is truly the person themselves. So as long as they're still in that phase, they may be able to learn because they want that trigger, right? Or they want that motivator. If not, you probably have lost the ability, the person has lost the ability to learn new information, and then an external motivator won't help. So Eunice says, I think it's all the stuff that hits you. Yeah. I'm so sorry, Eunice. I know. And that's not uncommon either, but I would recommend you, try to maybe talk to your pastor or talk to talk to your doctor and see if you need some additional support. Make sure your nutrition is good, and it is okay to cry. You just lost your mom. It is absolutely okay to cry. So no more other questions, John William. I hope that answered your question. So I'm going to go to Mike's question from earlier this week. Mike had a great question, and I'm finding a lot of people ask this question, so I'm going to answer it here as well. Mike says his 67-year young wife Sharon has been living with Alzheimer's for 5+ years. Early last month she had COVID. She recovered physically in about 2 weeks, but the last 2 weeks her moods have changed. He feels that she's a regular Dr. Jekyll and Miss Hyde. One moment she can be very happy and sweet, and then mad, and then sad, dark, but not violent. When she is mad, it's almost like delirium, where she talks out loud to herself and me. She's not hallucinating, but seems a bit paranoid, saying things like, "Nobody likes me. I've got to get out of here." He said they were going to the doctor the following week, and I need to follow up with him. And that they were going to look at some medication and so on, some thoughts and suggestions. So, Mike, I'll tag you in this post, after this, and I will be, let's start with COVID. COVID's been interesting. COVID really has been very interesting. It is, my limited experience. I do work with people with COVID. I go into their homes, but they're usually further along in their COVID journey. I'm not working in an acute hospital where I see them. Some people come home with COVID where they're still COVID positive, and I get into my hazmat suit and do all those fun things. But for the most part, the people that I see are a little further out. And so what I have been noticing about people with COVID is that there are some cognitive, there's a cognitive component to COVID, and whether it's probably like a delirium, and the difference between delirium and dementia is the following. Delirium is usually a short-term thing. There is a specific root cause. Things like a UTI cause delirium. Sometimes pneumonia can cause delirium. Sometimes a yeast infection or nutrition, or lots of things can cause delirium. Delirium just kind of means changes in people's thinking that happened like this, right? Dementia is more a gradual process, has different causes. There might be, research is showing there might be a component of lifestyle to dementia, that if we can change some of those lifestyle components, then we can maybe improve people's cognition. So, Mike, I would say this might be still a short delirium episode, or the COVID infection. The other option of it is the COVID infection precipitated a staging of her dementia, where she's going from one stage of dementia to a lower stage of dementia. We don't know why people go from one stage of dementia to another stage. I've never noticed, over the thousands of people that I've seen with dementia, I've never noticed that there are particular events. Sometimes sometimes delirium causes a particular event that causes the person with dementia to stage down to the next stage. It could be that the damage in her brain from her dementia is now going into parts of her brain that actually cause hallucination and paranoid ideation and things like that. So that is where I would start. But back to the conversation from earlier, don't discount looking for a trigger. Back to the whole behavior, her behavior of talking out loud and saying things like, "Nobody likes me, I've got to get out of here." Those things are a behavior. She's demonstrating a challenging behavior. Look again, so we have the infection component, right, the COVID component of this, but look and see if there are actual triggers, if there are actual um, befores, things that are in the three things we talked about: the care provider, the person themselves, which could be the COVID, residual infection or not getting through it yet, and the environment. Was it something going on in there? And see, and diarize it. Diarize. I cannot emphasize more to people who are helping people with dementia. If you see challenging behaviors, write things down, because and not one day, right? This has to be something you do every single day, because patterns are shown. And it's fascinating, working with people with dementia. Sometimes, because we're so close to the situation ourselves, we do not see the fact that, because we live in our homes, right, that their brain cannot process all the clutter that's around them. Their brain cannot we can tune the TV out. That television might just be on the whole entire time, and their brain can't tune it out, and it's like whoosh. So I would still diarize. I would write it down, and then do follow up with me in a message if you don't mind, and tell me what the doctor said, because I love to learn myself, and COVID is very new and different, and we're all in this boat together learning about COVID. So go ahead and message me if you don't mind, Mike. And then Lori, my Miss Lori, I don't know if Lori's still on. I should have answered her question first. How is your dear husband, Miss Lori? I hope you're still on, but if not, I will tag you in this again. And I will make sure that you hopefully can watch it later on. And we will start with your questions. Lori had three. Hey, Lori, my friend. She had two questions. He grits his teeth. Her husband, just to set the stage, Lori and I talk a lot, so I know a little bit about her husband. Her husband, I don't remember how long he has had dementia, but he's had dementia for a significant period of time. And he lives in a nursing home. She is his wonderful support system. Lori is doing such a great job, even though she is not his primary physical caregiver. She is his advocate, which is super great, because that is what we need, right? And Lori, I am so glad to hear that you might be able to go see him in the nursing home soon. So her husband's in a nursing home. He has end-stage dementia, and she has a few questions for me. The questions are about gritting his teeth. You can hear him grinding his teeth, and that he refuses to swallow. So I'm going to start with the refuses to swallow, Lori. If you, and I hate to say this, your dear husband, your wonderful husband, and I know you love him very much. We've talked about him a lot, you and I. He sounds like he's an awesome man, and that you guys had a wonderful marriage, and that it was, you've got a lot on your plate, I know. Unfortunately, though, and it's the hard reality, right now, dementia is fairly consistently a terminal process. So I've started to develop, some things that I'm working on in my head, and I've come up with this analogy that our lifespan, our lives, is like being on an airplane, right, on a flight. We take off, which is our normal development. We're born. We have a runway, right? That's where we're in mom's tummy. We take off. That's our developmental process. And then we fly. That's our life, right? And then, I hate to say this, everybody is going to die. Some of us just know that we are going to die, right? People with terminal processes like cancer, brain cancer, lung cancer, people with congestive heart failure, who are very, very sick, people with dementia. Some people know we're in the end stages of our life, right? So if you go back to the flight, takeoff, flying, what happens in our flight, right? That's life. We have ups and downs, we have some turbulence, we have some illnesses, we have life. That is our flight. But some of us know that we are in the end stages of our life. And Lori, I unfortunately know that your husband is at the pretty close end stages of his life. If you go back to normal development, one of the very first things that we develop and that we can do when we are born is swallow. So when people start to lose the ability to swallow, and what you mentioned about his saliva, managing their own secretions, when people start to get to that point where they're not able to manage their own secretions anymore and swallow effectively, where their brain is not sending that very, very basic message to them, they're getting very close to the end. What happens, or what can happen, I've had people ask me before, how do you die from dementia? Well, typically there's only two ways people die. Some people die with dementia, and some people die because their dementia has gotten so far that there's just nothing left, and then they pass away, right? But frequently people die with dementia because of a secondary thing. So dementia per se doesn't kill, right? Cancer doesn't necessarily kill either. It's just that cancer takes away all of these things that we are able to do. Dementia does the same thing. So when people lose the ability to swallow, Lori, and manage their own secretions, it's not that he is refusing to swallow. It's not a volitional thing. He is not doing it on purpose. He's not sitting in his head saying, I'm not going to swallow. He physically cannot, his brain is not sending that message anymore to swallow. What can happen is that because he's not swallowing, and we all have saliva in our mouth, even though we're not taking a drink, something being put into our mouth, when we are not swallowing our own saliva and we're pocketing it in our mouth, that saliva that has bacteria in, because our mouth has bacteria in, food pieces, sugar from drinks, food, that kind of stuff, right? What can happen is our body has two pipes, right? We have our windpipe and we have our esophagus. We have the I can never remember the word, trachea, which is the windpipe, and we have our esophagus, right? The esophagus is the swallowing pipe. So we have a windpipe and a swallowing pipe. So what'll happen is we have the uvula, the little flappy thing in the back of our neck. Everybody has that. When we swallow, that little flap closes our windpipe, so that the food and the saliva and everything goes down into our bellies, into our stomach. And when we have saliva or food or a drink or something in our mouth that we're not actively triggering a swallow, right? When we're not actively triggering that swallow and that stuff sits in our mouth, what can happen is, because the uvula, the little flappy thing at the back of your throat, isn't closing the windpipe, that stuff trickles down into your lungs. And what can happen over time, Miss Lori, with that is that the food or particles or the bacteria or whatever causes a pneumonia. Okay? And so that's called aspiration pneumonia, which is just the big fat fancy word for saying stuff went down the windpipe, right? And caused pneumonia, as opposed to an organism on the outside that causes a pneumonia. So when that food goes down into a person's lungs and they get pneumonia, that aspiration pneumonia can sometimes then be fatal and cause them to pass away. Unfortunately, at this really late stages of dementia, Miss Laurie, um, you have very limited possibilities. Some families have not had the conversations, or husband-wife couples do not have this conversation early on about what to do about supplemental nutrition, right? So we want our loved one to live. And a lot of people, and I don't know what you feel or believe, but a lot of people want their loved one to live as long as possible, and they decide to put in a feeding tube because um, because of the fact that they're not eating, not necessarily understanding that this is a terminal process, and that all that putting a feeding tube in will do for your husband is extend possibly some days in his life, but it is not going to extend his quality of life. So that is something that I would strongly encourage anybody who listened to this today to think about, talking to your loved ones early on in the phase about a feeding tube. Because if, going back to my airplane, my flight analogy, when we're in the descent to landing, and if you want to think landing the plane is the terminal process or death, some people might still crash while they're landing, which would be something else, like a massive stroke or a heart attack or something that actually kills, has them pass away. So I'm glad, Lori, that you have a DNR. I'm extremely glad to hear that, but um, I would encourage you to strongly not consider a feeding tube, because all a feeding tube really does is extend numbers. It doesn't extend quality. It's not going to change his quality. The fact that he is not swallowing indicates that he is very close to the end of his life. And so I'm praying with you to get in. Keep being his advocate, right? The other thing you can do, the only other thing that I truly believe is an option, is try to have the nursing home get a speech language pathologist in there to see if he's on the right consistencies of food. So you have a honey consistency, which is the thickest type of liquid. If you think about water and pouring water out, water is a thin liquid. If you think about like a tomato juice or something like a peach juice or a nectar consistency juice, they go down a little slower. And then you have the honey consistency and then pudding. So I would do that. So Lori, you asked, does he know what's happening to him? I don't believe he does. What will happen with dementia over time is, like, I'm sitting here at my desk, I can see outside, right? I can see people driving up and down the road. I can see all over there in the virtual world out there. People with dementia, their world goes from out here in until finally they are just aware of what's around them, within the 3 to 6 inches around them, right? So everything kind of goes in and in and in. And just like an infant or a baby, it will be that infant or baby will cry when it's hungry. It will maybe smile, it'll make eye contact and smile at you. It might reach for things as it starts to be aware of stuff around him. So initially, a baby doesn't actually actively like reach for something, right? You put your fingers in their hand and it closes. That's a reflex. You put your fingers in a hand and it closes. When a person with dementia can see an item and still take it and know what to do with it, that is a higher stage than somebody putting, you have your hand and you put it in and they close their hand. That's a reflexive action. So so does he know what's happening to him? Not the same way you know what's happening to him. He knows he's hungry, maybe, when he's hungry, because a lot of people at this end stage of dementia they're not hungry. When people are actively dying, they are not necessarily hungry. And I don't know that he's actively dying, but he's definitely in the end stages of his life. He may know he's hungry and thirsty. He might start to squirm or move when he's uncomfortable. So he might not be able to tell people he's uncomfortable. He won't be able to tell somebody he's in pain. So we use the nonverbals, like if they roll him and he winces, he might be hurting when they move him. So they will try to use his cues to help facilitate his care. But no, I do not think that he actively knows what is going on right now anymore. But he will still touch, smells. So when you go visit him, when you do get an opportunity to go visit him, if there was a favorite perfume that you wore, tap into his senses, tap into his sensory system. If there was a favorite perfume that you wore, wear it, take it with you. Say to him, honey, smell this, rub it on him, love on him in that way. If you guys had a favorite song, sing that to him. Be close. Don't try to talk to him on the other side of the room. Be very close. Be right there. And so, that kind of answered that question. The other question you had is he grits his teeth and you can hear him grinding. So that is a reflexive thing. It's called bruxism. I can't say that word. Honestly, I don't think there's anything that we can do about that right now. It's probably more disturbing for you than it is for him. So I would not worry too much about the bruxism, the teeth grinding. It probably drives you nuts. It would drive me nuts. But he probably isn't aware that he is doing it. And I don't think, he's not chomping on a burger right now, so wearing down his teeth isn't the issue. Oh, Jennifer, I'm so very sorry. Is there any way that I can help you? Do you have any questions? We have about 10 minutes left. I know it is a very difficult conversation. Nobody wants to have these conversations with people. Hospice is something we don't necessarily add earlier on. I would strongly encourage people out there, anybody who has watched this, we want to talk about these things earlier, and we want to talk about end of life. We don't talk about this soon enough. So John's comment was he agreed, don't consider a feeding tube. It extends yes, it's a very emotionally troublesome condition. The speech the pathologist is a great idea. They can give ideas for better quality of life, and at least to prevent as much as possible, because the saliva, back to Lori, the saliva is the problem, prevent as much as possible aspiration pneumonia. Anybody else have any questions so far? So Jennifer says, my mom will sometimes chug a drink. Seems like a reflex, not really sure she is thirsty. Afraid to stop offering the drink. don't be afraid to stop offering the drink. If she has, so here's a little known rule. You got to be your patient. You got to be your family member's advocate, right? So you all, my family out there, you guys in this dementia support group. Here's a little known rule about hospice. Hospice is a bucket of benefits, right? So Medicare A has several different buckets of benefits. One is hospice, one is home health, one is when a person's in the acute care hospital. So a very little known rule about hospice is it is not contraindicated to actually have therapy while on hospice. The difference is that the purpose of the therapy is not to improve that person, it is to improve quality of life of that person. It is typically only 1 or 2 visits to do caregiver education and to help the person have the best quality of life while they're on hospice. What you might consider doing, Jennifer, is ask your hospice agency for today's speech therapy day, for a speech therapy consultation to make sure that she is on the right liquids. The problem with chugging is most of the time that's a really fast thing, right? Quick, 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 quick. Chug, 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 swallow, 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 swallow. So sometimes if somebody's chugging something, they may actually have liquid going down into their lungs, and back to Lori's question earlier on, actually then potentially be at risk for pneumonia. So there are some strategies you can use. There are some solutions. The speech therapist can tell you whether or not the liquids that she's on is the correct liquid. So there are some mugs, there are some cups and things that have a liquid control thing. So you kind of think a sippy cup for a kid, a little kiddo. Sippy cups for little kiddos, because they have to suck, kind of limit how much fluid they're getting. Well, people with dementia cannot necessarily suck as well, but there are some cups out there that can actually control how much liquid they get. You could try something that might not just be a glass like this, or something that that might have a lid, that might be a little bit slower, where she has to work a little harder to get it out so she's not chugging it down. So you could, certainly try to ask the hospice, but you have to be pretty, you have to be your person's advocate in that and say, we know this is not to get them better or stronger, but I want to know if there's anything else that we can do to help with this. So that's what I would encourage you to do. So Kathy asked a question. I'm going to answer Kathy's question because it was from last week. I'm going to answer Kathy's question real quick, and we're going to talk about that real quick. She was, that is 100% true, John William, and so can an occupational therapist. Hoo-hoo, that would be what I am. Looking for ways to get her mother to drink her prune juice. She's not cooperating. Is there a better tasting drink that would help her constipation? So yet again, it's really hard. We want to try to realize that people with dementia, especially in the later stages, they're not doing this on purpose. They're not cooperating. That is a challenging behavior. So her not wanting to drink the prune juice is probably because the prune juice doesn't taste good, right? Or she doesn't like the texture. There could be a lot of reasons. So what I had suggested to Miss Kathy, and this one's going to be a quick one, what I suggested to Miss Kathy is sometimes warm prune juice is a little bit more palatable, but you could try to mix it into something else. But prune juice does really. Thanks, John. No, it's okay. I don't mind. I don't mind. I can. I'm good at. I'm good. Um, so anyway, back to Kathy's question. Constipation is very common in dementia. Water helps. Trying to get people to drink a lot of water. Physical activity, moving around helps your bowels move. Hot prune juice. You can do steamed prunes if people like prunes. I'm trying to think. Hot apple juice sometimes works. I don't find it to work for me, but sometimes for some people it does. But a lot of medication, Miss Kathy, think about this. Look at medication. Call your pharmacist. Say, is there anything that mom's on that's actually causing constipation? I'm just got to write myself a note here. So constipation can be caused by not enough fluids, not enough bulk. Try to give her more fibrous foods, vegetables. There are lots of tricks like that. So I am glad you guys were here. I have like 3 minutes, so I was going to pumpkin pie without the crust. That's a good idea. That's a really good idea, John William. So Jennifer said that's what she's afraid of. She's going to try a sippy cup, do ice chips. Very late stage. So Jennifer, just about the ice chips, if your mom is at the really, really late stages, banana, yay, banana. Banana might work. That's great, Lisa. I did not know that. See, learn something new every day. So Jennifer, ice chips, just if your mom is at that very, very late stage, ice chips turn into thin liquids. So if she's on a thick liquid, just be aware of it. If hospice expected her to die last week, I would just keep your mom comfortable. If your mom's the one that's chugging, then I honestly, just keep her comfortable, love her, be close to her. Going back to what I told Lori earlier on, just because she's at this late stages doesn't mean that she doesn't know that you guys are there. Try to tap into her sensory system. Try to find lotions that smell good. Touch her, love on her, be close, make memories. If she's in your home where you can be with her, try to give her sensory input that she would have enjoyed in her life. If she liked coffee, maybe give her the smell of coffee. Ground up some coffee, take it to her and smell. Say, here, Mom, you loved coffee. Let's smell the coffee together. Or if she had a favorite, if your dad, if he's still alive, if he had a aftershave or something that he wore, that you can take to her and rub on her, so she's getting this sensory input so that she knows that you guys are still there. Sing to her. As stupid as it sounds, sing to her. Music taps a different part of our brains and is very compelling. If you had favorite songs, try to get to the things that she would remember, things from her childhood. Doesn't matter how stupid you feel. Make the memories. And I know this is hard, guys. Take photos. Take videos. I know I'm about to cry. I know how hard it is to take those videos of your family members in this stage, but they're still your family. And we're so afraid of taking videos, but you're going to be grateful later on to have taken those videos and made those memories. Hop on the bed, get with her on the bed and take videos and love them. So I hope this was helpful. My name is Lizette. I'm an occupational therapist, and I've got to collect myself. I'm getting ready to hop off here. This is my gift to you once a week. It's called The Baffled Brain, Demystifying Dementia. It is my weekly hour-long Facebook Live that will teach you everything you want to know about how to manage dementia. Today is February the 20th, 2021, and this is episode 13, and I was your host, Lizette Klute from Think Different Dementia, where we believe caregivers deserve the reliable answers to answer questions to provide clarity and improve their quality of life, because having actionable strategies and information gives caregivers and people with dementia improved quality of life and better relationships. I invite you this morning. The one thing I ask of you guys, if you've enjoyed this, please join my private Facebook group called Think Different Dementia. I also have a YouTube channel called Think Different Dementia. Join that. I love to teach. I love to dialogue with you guys. I really want to serve you. And I don't know, I can't serve you if you guys aren't in my spheres. So please join. Like I said, Think Different Dementia Facebook group. I have a YouTube channel called Think Different Dementia. I'm very original, right? And then my email address is also thinkdifferentdementia@gmail.com. So I will throw that in the comments. Thank you for joining me this morning. I will see if anybody else has said anything else, but I am getting ready to leave. Have a wonderful day. God bless. What a wonderful hour this has been, even for me. Some tough topics today, but I am very, very grateful for all y'all. And my goal for myself this year is 1,000 questions for you guys. Thanks, Eunice. God bless. And I will be back next Saturday at 8 a.m. Bye.